Welcome, everybody. It is January 24th. It's Friday, and we're very excited to have um, a local um, a local paramedic who's a really amazing guy. I've known him for a long time, and he's doing some things that all of us need to hear. And he did me the favor a few months ago, and he actually gave a version of this talk to some friends in South Carolina. The other special thing is that what he's talking about today is something that was developed out of Wichita. Sabina Braithwaite, who's everyone knows is an EMS medical director, and Paul Masaki, who's on the EMS leadership there in Wichita. And they have published on this topic. And then we have folks like Ian who have taken this topic and are now trying to get it out to the masses locally, regionally, just to help each other out. And fascinatingly, many of you may have seen what just came out on the news wires yesterday, which was apparently there was a paramedic who has been charged criminally for a medication error. So it's incredible what's going on. This topic is very, very important. And again, Paul and Sabina, thank you for joining. And Ian, I'm going to give you the reins. Take it away, my friend. Thank you so much for coming on the Florida EMS webinar.
Absolutely. Thank you, Dr. Antevi. You guys can see my screen and hear me. Everything's good?
Perfect.
Perfect. Awesome. All right. So thank you so much. I appreciate being here, Dr. Antevi, Dr. Pepe, Tanner. I mean, honestly, I see you on here all the time, so it's cool to actually get a part of this. I've got 15 years in EMS and fire. I was the lead instructor for an outstanding paramedic program, training captain for about 4 years, and I focused on EMS, and I was on a competition team like a nerd for the ALS competition. So I really love EMS, and I bring that up because I hadn't ever one time considered the process in which I administered medications on the job. We just kind of did what we did, and it never occurred to me. The impetus of how we got here was a few of our peers trusted us and it told us about some of their experiences, and they helped us recognize a blind spot that had developed over time. So hopefully my goal today is to inspire you to survey your own systems and see where you have the same opportunities for improvement. I had absolutely no idea that these people would be here. This was just part of this, but Paul Masasi and Sabina Braithwaite were phenomenal. These are the folks that created this whole thing. They implemented it, they tested it, and they were incredibly gracious with their time. They shared all of their info with me, and they're just genuinely kind people. So everything that's here today started off with them just being kind enough to meet with us. So thank you so much. So this is kind of recent. This was in Newport, Kentucky. This was in 2022, and the lawsuit was in 23. In February of 22, Newport Fire and Rescue were dispatched to what you see in the picture, the Ovation Theater, for a fall with injury. They had one patient who had fallen and struck her head, had a laceration. They transported her for the laceration and for concern of a closed head injury. And almost immediately when they got into the apparatus, the patient stated that she felt nauseous and like she was going to pass out. This particular patient also happened to be a medical professional. She was a pediatric ER nurse, and she requested Zofran. So they agreed with that. One paramedic went ahead and grabbed the medication, syringe, pulled up 1 cc, gave it over to the second paramedic, and he administered it through the IV. At some point after that, they realized that instead of pulling Zofran, they had accidentally pulled epinephrine 1000 and administered 1 ml of that IV. To be fair, they did the right thing. They informed the patient, they told the hospital, they told their system, they monitored the patient. But a year later, lawsuits started showing up in the news, and there's a couple of things from her attorney that seemed pertinent here. One of the things they talked about was that neither medic looked at the writing on the vial to verify the medication, nor did they verbalize what medication had been drawn, handed off, or subsequently administered in the IV. These protocols were disregarded in their entirety by both medics. As a direct result of the defendant's negligence, gross negligence, wanton and reckless conduct, which sounds horrible, the plaintiff suffered what they're calling in this article a medication-induced MI, With heart damage, that's going to be permanent, and experts say she's taken 10 years off her life, which I don't know how you can figure that out, but that sounds horrible. When we see things like this, we try to find the utility in them. There was already a mistake made, so how can we learn from this and make sure that we don't do the same thing? So we started off with just wondering, okay, Zofran, what does this look like for us? We generally get the same Zofran almost all the time. It's a green vial with green writing and top on there, 4 milligrams and 2 mLs. Every once in a while, we get one different one, pre-filled syringe that's almost exactly the same. But out of curiosity, I did a Google search and I did images just to see how many different ones there are. And what I found was pretty much every color combination you could possibly think of for the same medication. And then when I started looking at these and I see the ones that are kind of purplish pink and I see the ones that are kind of a blue and a purple, and I do the same thing for epinephrine, I can see how this can happen. I can see exactly how this could happen, especially if you didn't have a system in place. There are a tremendous amount of medications out there right now that look almost identical. And with supply chain issues and medication shortages, I think it's reasonable to expect that every agency is going to get meds that they're unfamiliar with the packaging. So one of my chiefs reached out to me and asked me to talk to our neighboring agencies and find out what they were doing for medication administration. So I called a fair amount of agencies. I called people from Miami-Dade through Palm Beach County, and I wanted to know what is in your policy and protocol, what do you go through? And really the responses were the same as ours. They didn't really have anything. They made some assumptions, what they thought was going on, but nothing that was actually in writing. The only feedback that I got was that some people assume they use the 5 rights. And I think it's bold to think that every crew is out there methodically banging out the 5 rights for every medication administration. To be honest with you, I don't even know what they are anymore, because when I went to school, it was the 5 rights. And I think when I left, we put in a 6th one. And then as time went on, they became more. And as we're going through this, the last one I saw was the 16 rights of medication administration. One of the things that I learned from Paul and Sabina was that a big flaw in these is that they're typically done independently, and you're depending on the person that's making the mistake to catch the mistake and fix that. And that's not highly likely to happen. So when we saw the MACC, we were super excited about it. The medication administration cross-check is a 2-person verbal and really visual procedure, and it deals with preparation, validation, and confirmation of your administered medications. Essentially, provider 1 does the skills, provider 2 does all the authorizations. If there's any interruption, they make sure that they figure out what happened and that they don't move on until everybody's in agreement. It's got error traps built into it, like volume and concentration verification, and it's brief. It takes about 15 to 20 seconds to do. It doesn't take much time at all. This is the way it's pretty much laid out. They use clear, unambiguous language. So provider 1 is going to use the same term. We decided to go with med check every single time. Provider 2 then engages with the same idea, clear, unambiguous language with the word ready. He's not going to say sure or go ahead. He wants to let the first provider know that they are both locked into this process. From there, provider 1 just says what he's going to do. I'm going to give 100 micrograms of fentanyl IV slow push for pain. If provider 2 agrees with that, he'll say contraindications. He'll ask his first question. If he doesn't, he'll resolve this before they go on. When it goes to contraindications, the 3 that they list in there are allergies, vital signs, and the medication being expired. But this is also an opportunity for provider 1 and for provider 2 to share information. Sometimes one person knows about something on a call the other person hasn't heard. And so if provider 1 doesn't know a contraindication is there or a relative contraindication, provider 2 can now fill them in. But as long as there's no contraindications, they can keep moving through. And then provider 2 will ask about volume, because they told me they found a lot of their errors in this area. So he asked for volume, and provider 1 shows the syringe and the vial, talks about what the concentration is and how much they've drawn up, and basically gets a verbal and a visual verification. As long as all that's good, provider 2 then gives the confirmation to go ahead and give the medication. It's simple. Provider 2 has to remember to ask 2 questions. Provider 1 just has to do what they intend to do. You have the medications that can't be given without the completion of the cross-check. So you're inserting another person as a barrier to that error for coming to the patient. And it creates pause points, which is phenomenal because a lot of times we're dealing with really stressful situations, and it's nice to have a way to sort of get back in check. So we're decreasing medication errors, we're improving teamwork and communication, and we're giving a uniform medication administration for practices, a consistent one. One of the other things that I thought was really amazing too was it's in the textbooks. So this is from a class that I teach. This is the Nancy Caroline book, and it's literally in their pharmacology section. I don't have the Brady book, but I'm told it's in that as well. So it's being taught to students as they're coming out. It's been out there since 2013, at least from the presentations. It's just not being picked up on for some reason, and I think it's a tremendous missed opportunity. This is some of their data. So they're here, so you can always ask them too. But they did a 54-month, 27-month pre-MACC and 27-month post-MACC study with their medication errors. And what they found I thought was pretty amazing. Now, number one, I had no idea about Sedgwick, and I didn't know if they were busy or not, and they run a lot of calls. So they had a ton of data. In that 54 months, they gave about 73,500 medication doses. They actually had an increase in their medication doses post-MACC implementation of 12.9%. But even with that increase, their error count went down by 43%, and that's across the board for medications. That's a pretty phenomenal number. Now, if you're like our system, we track some medications better than others. They're not all tracked equally. Controlled substances are much, much better managed. So if we give Epi or Zofran, to be honest with you, we don't tie it back to the call and make sure that the dosage was correct. But with controlled substances, we need to see the waste, we need to tie it back. So those numbers are really interesting, and they had those. Their fentanyl doses went up post-MACC implementation by 54%. But even with that increase in the amount of fentanyl, and you can see the numbers are huge, they gave 4,300 doses post-MACC implementation, their error rate went down by 71%. So that's pretty phenomenal. So you have a tool that works. The cross-check works as long as you actually employ it. And that's what I didn't understand. So when we go through this today, I want you to just think about a couple things, and that is, in your system, how are medications being administered by your agency? Whether you are a medical director or an EMS chief or you're one of the people in the field, you have an expectation of what is happening out there, but do you know that that's what it actually is? And if that is what your expectation is, if it is supposed to be happening, where is that information located? Do you have it in a policy? Is it written down in a protocol or a guideline? Do you have it as a verbal reference? Like one of the departments I talked to said that in their recruit camp, they verbally tell them and they pass it down that way. Is it expected? Do you say you went to paramedic school and you should know how to do a medication check? And if that's the case, then what else is expected? Because when I look into the procedure sections of protocols, I see how to put on electrodes and how to start an IV and a lot of things that are less dangerous than medication errors. So when we became aware of the errors and I spoke with the agencies and I saw that there was really nothing in writing, I didn't really understand what the disconnect was. I wanted to know why they didn't feel an urgency and why we don't really realize a lot of the benefits that the MACC can be to us. And I pretty much looked at these 5 things: insufficient medication data and accountability, a lack of standardization, stressful environments, cognitive overload, and then some of the cultural barriers that we have in fire and EMS to reporting and improvement. I want to talk about those a little bit right now. The first one, insufficient medication data and accountability. I tried to find information on pre-hospital medication errors, and there's not a lot out there. A lot of this stuff is actually behind paywalls, and anytime I went out to an author and I asked for it, I was able to get it. But even behind paywalls, there wasn't much. I actually talked to a guy from Australia that had a really good, a lot of good information, but still not a lot out there. And when we look at our controlled substances, sure, we're tracking those, but When we're looking at other things like calcium, dextrose, Zofran, there aren't systems in place to account for those meds, nor are we really tracking any pertinent data like what equipment was used. And what I mean by that is if I go to my EMS captain and I say I need to replace my epinephrine and I need a 10 cc syringe, at that point there should be a 10 cc syringe. Why would you need that? And maybe that brings something up, but for the most part, we can just go and restock our equipment and nothing is really tied back. So I wanted to find something that would be hopefully around the same realm, or at least give us some kind of data. And I decided that we would look at hospital numbers because they're not the same as us, but they kind of have the same thing. I'm going to use a transitive property that is completely unscientific and just assume that if it's happening there, that it's happening with us as well. When I looked at hospital data, for the most part, I saw that for every 100 admissions, they had somewhere between 5 and 10 medication errors. The last one I read was 6.5. Now that's happening with doctors, nurses, paramedics, pharmacists, Pyxis machines, scanners, bracelets, computer programs that give you error messages, a ridiculous amount of things that we don't have in EMS. This is one hospital's algorithm for their medication administration within their system. And even if yours is not exactly like this, it's somewhere in the same way. And it's not what we have in EMS. So if they're having 5 to 10 per 100 admissions, I would have to assume that we're having something along the same way. We just don't have a way to track the numbers right now. A lack of standardization. You're having a lack of standardization in school all the way through to when you're actually working in the field. You can go to a school and in the exact same class have 2 instructors teach you how to do something completely differently. And then when you get transferred to the field, when you're in practice, you do the same thing. What we see a lot of times is guys will say, on my truck, this is how I check it out. We hold it up and we look at it together, or we do this. But doing that doesn't give you a standardization. We haven't even agreed on what a medication error is, to be honest with you. I'll show you a couple things that have been shared with me, and I'll ask you, are these medication errors or are they not? These are all real calls that happened that people were kind enough to share with us. The first one was for an urgent care for anaphylaxis. The crew went out there, the officer assessed the patient, he agreed anaphylaxis, and he asked his crew to go ahead and give IM epinephrine. He stayed to talk to the doctor, and when he got back in the truck, instead of giving 0.3 mLs, they said, we made a mistake. We accidentally gave 3 mLs, which is 10 times the dose. Another call was a pediatric cardiac arrest. This one was with epinephrine 110,000. The crew did everything the right way. They went and looked at their length-based tape. They got the color that was appropriate. They looked at the mLs that needed to be grabbed, and the person who said it said, listen, I'm going to grab this many mLs of epinephrine 110,000 and got agreement. The only problem is everybody was doing other tasks, and when they grabbed the medication, they grabbed 1,000 and put that in. And again, we're at 10 times the dose. This one was just as much my fault, if not all my fault. This was a ketamine administration, and we were in charge of training the initial ketamine that went out there. And we didn't do a good enough job of showing people how to use the pediatric tools that we had. This crew was amazing. So we were using ketamine like some of the other agencies are, where if you have a seizure that's refractory to benzos, you go to ketamine. And this crew did an amazing job of looking at the CAD, seeing that medication had already been pushed, and calling a supervisor with ketamine to come out there and meet them. You had a lot of people there. You had a rock star paramedic, a dude who is phenomenal at what he does that was giving the medication. But because of the unfamiliarity, we didn't realize that he had to dilute it into 50 mLs. So when he gave the 3.5 mLs, instead of giving 35 milligrams, he had given 350 milligrams. And you see a common theme here where a decimal point changes a lot of things. Here's a different one. We had a pediatric seizure, and the crew went out there, length-based tape, saw what they needed, and they had to give 1 milligram, which was 0.2 mLs. This particular agency has never really had a different concentration than what you see here. That's 10 milligrams and 2 mLs. Because of supply chain issues, because of whatever else has been happening, they happened to get a different concentration in, and the crews were not aware of it. So they actually had both concentrations out there. When the crew went to give the medication, instead of giving 10 milligrams and 2 mLs, they grabbed the one that was 5 milligrams and 5 mLs. So their dose was really 0.2 milligrams instead of 1 milligram. Now, when I talked to them, they said, hey, at least we didn't overdose them. That's better, right? And my thing is, no, you gave about 1/5 the dose. And if it's one of my kids and they're having a seizure, I want the full dose. I want the dose that's going to stop it. I think these are equally as bad, equally that we want to take them and make sure they don't happen. So I ask you, are those medication errors? Because discussions were had, and what I was told is that those were not medication errors. These were familiarization errors, they were awareness errors, they were protocol errors, they were anything else except a medication error. And so how do we sit there and collect data if we're not even going to agree on what a medication error is? So we decided, let's look for a definition of what a medication error is and at least use that. We went to the National Coordinating Council for Medication Error Reporting and Prevention, and we saw what they had on their site, which is a phenomenal definition that's pretty all-encompassing. The only thing is, this is a lot to take to the stations and to talk to people about. We want to simplify things as much as possible. One of the things that they have on their site that I thought was really, really insightful is the effectiveness of how we classify these, and the resulting analysis of these reports is dependent upon the amount and quality of the data collected. So if we're not going to collect these things as being data, we're not going to ever know how to fix this. So we tried to work through what would be hopefully an easier way of looking at a medication error. And we just decided, can we try this out? Did you give a medication? And if you did, was there an error? And if there was, we'll call that a medication error. And then we can get to the root cause and 5 whys and anything else you want to do. But let's at least get to the point to where we're agreeing on that. There's an asterisk here because we also want to look at omission. If you were supposed to give a med and you didn't give a med, then we want to know why that was as well, because a lot of times omission can be as bad as commission. When you're telling people that they made a medication error, because of the culture, a lot of times they will become defensive, and that's not what this is about. So we wanted to make a few things clear. One is that errors don't equal harm. So if you were on a call and you were supposed to give 35 milligrams of Benadryl, but you gave 40 milligrams, it's probably going to be fine, but you need to report that up because there's a reason that happened. Maybe the medication's changed. Maybe we got new syringes that it's really hard to see what's going on. But if you don't let people know that happened, then the next time that happens, it might be something that is not inconsequential and that is going to be much more substantial. The other part is errors do not equal culpability. People do not come to work with nefarious intentions to administer overdoses of medications. The majority of time when this happens, there is something in the background. There's some latent error that nobody realized that finally came out. So don't think that we're going to hold you in accountability for everything that happened. There is accountability, but we also have to look at what the background of it is. So now that we have a construct, we need a buy-in. We need for people to feel okay reporting them. So one of the people that is a mentor to me that was at another department was helping me out with this. And we came up with the idea of making a QR code. And that QR code would go to a Google Sheet, and you could anonymously report a medication error. The problem with that is that if it's only our 2 departments, they're not huge. And if you send a medication error up at 10:30 on a Tuesday, it's not difficult for somebody to go back in there. Not that saying that they would, but the person reporting it may not feel comfortable with it. So we started thinking more outside the box, and we said, well, what if we got more people involved? In our county, there are 18-ish agencies, and we're all pretty close to being the same in sense of how we practice and what medications we use. So what if we put this out to all of the different departments, and they had it in their stations and on their trucks, and then we put it at the hospitals because the ERs are using a lot of the same medications that we're using, and people could anonymously or not anonymously, because there was an option on there if you wanted to be contacted about it, which would be awesome, to share what happened. Then we're getting more data. People feel safer reporting it, and I think there's a lot more validity that will come, a lot more that we can gain from that experience. So that was going to be the goal. And the idea is also, Every one of these departments would be able to access this. They'd be able to see what was going on. You'd have one person that would be able to sort of control it and make the reports available so that multiple people weren't switching around things. But I could look at, North Lauderdale, Miramar, and Fort Lauderdale and say, well, if they're having an issue with one medication that we carry, it's only a matter of time before the rest of us are all having the same issue. So let's jump on this ahead of time. Next two we're going to put together, and that is stressful environments and cognitive overload. We work in stressful environments. I don't know why we wouldn't want to implement a system like the MACC that's going to help out. We're driving there, getting toned out. We're going code 3 through traffic. You're getting up to an unfamiliar scene. You have families there. You're working in the rain. You're working in the sun. Sometimes you're working on the side of the road. You have this sympathetic release. Time is skewed. It'd be nice to have the MACC where you have a pause point. You have a second person there that's going to help you focus and make sure that you're not making medication errors. I think we're also dealing with a lot of cognitive overload. There's another mentor that I have that in one of his talks, he talks about the tenacity of fire and EMS and how we can take on pretty much anything and then we excel at it. So whether it's COVID or hazardous materials or whatever else it is, they just basically give it to us and we figure it out. But at a certain point, there's just diminishing returns. So if we can put a system in place that can take some of that cognitive load off, we can put that brain power into other areas. And I think the MACC does that for us. Having that second person in there helps out tremendously. One of the things that Paul and Sabina had wrote in a paper that I believe they wrote was, this is not an attempt to dumb down the care we provide. This looks at the vulnerabilities of us as human beings and makes it safer for our patients and for us. So the culture is the last thing I want to talk about. Fire and EMS, you hear just culture, you hear culture of safety, and these are all great things. I believe in them, but they take a lot of time to work up to. It took years before people started to tell us about some of the things that they were going through that they experienced on their calls. People don't want to feel like they're going to be strung out to dry. You can have the fire chief and the medical director and everybody else saying that they're in a just culture. But if you have a shift supervisor that's down there and they're chewing everybody out and yelling at them, then they're undermining everything that you're trying to do. So if you're going to have a just culture or any kind of other place where you're looking at errors because you want to make them better, you need buy-in from every single person. You need to commit to that, and it's going to take a while. It's going to take a long time, but it's worth it. We're human beings. I think mistakes are the expectation. They're not the exception. We are going to make mistakes. That's why these systems and processes like the MACC are so critical. You have to know you made the error. You need to admit it, and you need to be in a culture that encourages the sharing of information. This is the last part where I normally talk about implementation, but I took it out for this one because I want to talk about something that I like looking at. And this is, if you ever go to the EMS Eagles site, I have no conflicts of interest. They do not pay me for this. I just very much enjoy the info there. They have a past presentation section, and you can go through a cache of just all these amazing things. So you've got, Michael Levy looking at mechanical versus manual compressions from 10 years ago. You've got Chris Cowell and his feelings on morphine. Corey Slovis talks about 5 whatever because it's always amazing. It's tons of great information. But one of the things I noticed when I went through them was I ran into these as well. And so I saw, presentations from 2010 from Dr. Gallagher on medication errors in EMS. And then I saw Sabina's in 2013, which was done much more eloquently and better than this. And then I saw that Dr. Gallagher came back and did it again. And these people are eminently more qualified and educated to address this topic than I am. And so if it's not being picked up by them, then I don't know what it's going to take to pick it up. The MACC, it's not just an algorithm. It's a culture thing. It creates a culture where providers are working together to provide the highest level of pre-hospital care. They're making it safer for the patients. And so what I would ask from you is to be a champion for safety. We need for the people that are here now to have that expectation and say that you're going to stick to it and that people are going to perform certain ways. safer patients, empowered providers, building stronger systems. If they can do it in Sedgwick and they can do it in Chicago, then I promise you, wherever you are right now, you can do it there as well. And if there's doubt and skepticism, that will leave the first time somebody finds a near miss that would have been an error had they not done this. So I would ask you to please evaluate your agency's current medication practices and see how you can improve them if there's room for approval. This is my information. I put the stuff that I got from Sabina, Paul, and everything else I found into a Google Drive. And so there's more that I'm going to update that I'll probably do today, but that's the QR code for it. But this is my information. Call me. I would love to talk about any of this. And oh, by the way, free labor. If you're doing any kind of research, I want to be involved in it. I want more understanding of just an abstract and a conclusion. So if anybody is doing anything and you want me to count compressions or look at strips, reach out to me. I'll do all the stuff you don't want to do. I thank you guys for your time and for being with us today, and I appreciate the opportunity to be here. Thank you so much, Dr. Antevi.
Excellent. Amazing. Amazing. Ian, great job. I love this presentation. And we are running short on time. So my apologies in advance to Dr. Pepe. We'll get to your webinar shortly, but we do have Paul on. We do have Sabina on. Um, you know, my question for you, Paul, if you wouldn't mind, you've been through this process, you and Sabina. It's been many years. If you can answer the question that Ian posed, which is, why is this such a difficult topic to be that's not being taken up across many systems? Start with that. And wait, before you actually, Paul wants to say something. Paul, go ahead.
Uh, um, okay. You want me to know why it's so difficult?
Oh no, I was going to ask Paul Mastasi. So different Paul, but you
Oh, I'm
can answer
sorry.
that.
Okay, apologize. Okay,
No,
got it.
no, it's okay. It's okay.
Yeah, I
It's
got to get
okay.
over to the other
Yeah, yeah.
session.
We'll be right over to you too. Sorry about
So,
that.
but before I go, Peter, I downloaded a certificate and tell everybody also on the CME that it says 1.5 hours. Obviously, you can only claim 0.5 hours. Okay, so that's all. All right.
I see. Okay, got you, got you, got you. Okay,
What to
thank you.
tell you, except I was able to do it. So, all right, thanks.
All right, thanks.
I sent you an email fact with my certificate. All
Okay, I'll take a look.
right,
All
I
right,
got to
thank
get
you.
off. I'll see you. Okay, bye.
Thanks, Paul. All right, so Paul Masaki, go ahead. Take that question.
Well, so it turns out paramedics are stubborn, and it also turns out that um, changing a culture is hard. um, because it's easier and frankly more emotionally gratifying to just go around thumping skulls, right? We are all subject to fundamental attribution bias. We're all subject to illusory superiority bias that are, ego protective. So we think we're okay. It's other people that are the problem. I could probably do this just fine, but those other guys, not so much. Um, and at least EMS, when I started as a paramedic a couple decades ago now, I was taught that I'm to be a paramedic, like, and think as if I'm the only Coca-Cola in the desert. And I'm going to have to be the one that runs this call and make sure everything goes right because by God, you got to be able to do this on your own. And it turns out EMS is actually a team sport, rarely carried out by one person all by themselves. And so, change is hard. But I think one of the smartest things we did in Sedgwick County was um, in establishing this as the standard of care. We also reached out to the local feeder community colleges that were sending all of their students to Sedgwick County for their internship and said, look, they got to know how to give medications this way because that's the way we do it. So
Right.
we got it in, so they would show up knowing how to do this better than some of our employees. But it takes a tremendous cultural shift, and I give credit to Sabina because it wouldn't have happened without her and her willingness to say, this is how we will do it. This is now the standard of care. But it also required, as Ian mentioned, an appreciation, and certainly Sabina's appreciation for what a true safety culture means. And it wouldn't have been successful without those components. So,
Well, with
I
that
think
being
that.
said,
Go ahead.
let's say, well, Sabine, I'm not sure if you're available to unmute yourself, but we'd love to hear your take on this as well before we move over to Pepe.
You bet. Thank you so much. And thank you, Paul. It was great having such incredible partners there. You can't do that. Like Ian said, you can't do this without a team. Paul used all the fancy words. I'll tell you some of the same things that Ian and I talked about, which is sort of the resistance to doing this. So the first resistance was, I'm not making mistakes. And as was mentioned, if you're not watching it, you don't know you're making mistakes. You can't report an error that you don't know that you made. So that was one thing. The second thing was, oh, we're going to look stupid in front of the patients doing this thing. They're going to think we don't know what we're doing. And so we actually scripted that as well. We said, hey, we're just going to do a safety check to make sure we're giving you the right medication, and never had any issues with any of the patients complaining. But that was another sort of barrier where people are going to think we're dumb because we're doing this. But when you tell people we're doing this for your safety, nobody has a problem with it. Another thing we heard frequently was, oh, hey, it takes too long. And to which my answer is it better to give the wrong medication quickly or the right medication 17 seconds later? And that one's kind of hard to argue with too. So,
Yeah.
so
These are all great points. Yeah, I mean,
those are the cultural obstacles that we kind of dealt with. But it was really amazing that it kind of got taken on. And I really give you guys incredible props for taking this over. My son's a firefighter in North Carolina now. And he's like, hey, they taught us this in EMT class. Did you have anything to do with this?
That's great. That's great. That's amazing. So, well, listen, thank you for all the work you've done. I want to bring in my co-host because he's the research brain here. And Penny, I hope you're listening. So Tanner, if you want to make a couple of comments, where do we go from here? And I would love to hear your thoughts.
Yeah, so I did have one comment and one question about this. First of all, Ian, thank you very much for the presentation. I'm very grateful that there's EMS clinicians who are out there who are passionate about solving problems on the front lines, and also it sounds like in a position to educate future cohorts of paramedics. That's really excellent. First of all, in terms of kind of generalizability of this, the medication administration cross-check to other systems, requiring two EMS clinicians to be in the back of an ambulance, and also for both of those clinicians to actually have knowledge of the contraindications, the dosages of the medications being administered, I think is a rarity. So I'm from West Virginia, and in our state, having paramedic units with two paramedics on board is a rarity. It's certainly the exception. For example, tomorrow I'm going to be working with just a driver for a shift in a county. And so, first of all, having that kind of two-way communication is not always possible, right? They might never have seen Zofran be administered or heard of it, right? A lot of these are BLS only kind of systems. And in addition, when most of these non-critical medications are actually being administered, so something like Zofran or Toradol or something, it's happening moving down the road when there's one provider in the back. And so in terms of kind of generalizability and limitations, that's one thing that came to my mind. Also, in terms of the question, the before and after data that you showed, looking at medication errors before and after implementation of this system, how did you define medication errors in that context? Because I know we talked about inconsistent definitions and how do we define what an error actually is, in relation to, I think fentanyl was shown or opioids specifically. Were some of these errors like 60 mics instead of 50 of fentanyl, something that arguably doesn't have a lot of clinical importance? And how many of these errors were actually like giving epi instead of Zofran?
So if I can jump in for a really quick
Sabina.
second, can I jump in for a really quick second? So when we did the practicals for this, because like I said, part of it was, oh, well, people said, I'm not making any errors. When we did the practicals and had them sit there in teams and do the cross check, invariably somebody found an error. And as far as who can do it, it doesn't have to be a paramedic. It turns out that people that are old enough to drive an ambulance can actually read a label too. And that even just the component of saying out loud what you're doing allowed people to catch errors sometimes, even by themselves. So it didn't matter who it was. I made the firefighters do this, the EMTs, for BLS medications, because guess what? You can make somebody really sick with several sublingual nitros and some aspirin, depending. So everybody had to do it for every med. This was not just for IV medications. And I'll let Paul jump in.
Yeah, so we've heard these comments and arguments. We've heard them all, and to underscore what Sabina just said, EMT, we don't give EMTs enough credit. Like you said, they can read. But one interesting organic development that happened at Sedgwick County was the EMTs themselves brought forth a little cognitive aid. It was a pocket-sized card that they themselves made, and it was a list of our most commonly given drugs and the contraindications. So even if they, didn't memorize the formulary, they would whip out their pocket contraindications card and say, "What are the contraindications there, dude?" And oh yeah, did you think about this one on the list? So they are able to participate in that more effectively than we give them credit for. Your last question, we counted anything other than the correct dose as an error. Oftentimes, Zian was saying, well, I gave an extra 25 mics of fentanyl, but the patient was fine. They felt good afterwards. It was a therapeutic error, and so my argument to that as kind of quality manager was quality is about getting our treatment right on purpose, not on accident. And that means we're going to count this as an error. It doesn't mean we're going to thump your skull or you're going to be punished of anything. It just means it goes down in the books as an error. Even if it was, here's one that would drive folks crazy, was a rule-based error. Like I was supposed to reduce the dose of fentanyl for this patient that was 67 years old, but the patient themselves told me they were 64. And so I gave the regular dose. When the registration sheet came out at the hospital, it turns out they're actually 67, and I had no way of knowing. Well, I'm still going to count that as an error. Nobody gets punished. It's one that was unavoidable, obviously, but it's something that we use to create awareness because the types of errors that happen are informative for your solutions. And if you're using the outcome bias, which drives me crazy, the no harm, no foul approach, you will never make qualitative or quantitative improvements in patient safety. It just doesn't work.
Anna, you want to comment?
Right, and those errors that don't reach the patient are still an opportunity. We found things like the syringes were hard to read, buy different syringes, and silly things like that never come up if you don't report everything and look at everything with a fresh eye.
Great comment. Okay, so we have Jana Ali. Jana, go ahead. What's your question? You're on mute. Unmute yourself.
Sorry, guys. I'm a nurse. I am popping in because I'm actually a nurse host on the Nurse Converse podcast. I'm doing an episode about a nurse who killed a patient, actually, through a medication error coming up soon. So this really spiked my interest, and everything that is being said from the medic pre-hospital side is happening on the hospital side, ER trauma as well. I think that this information should not just end with you guys. I think this should be brought into the Bay, into the ER. It's fantastic. What I do want to say is I'm no longer practicing bedside. I am in industry. And why are we accepting that the bottles are this big and they're the same and they have a green top? Great, but we could put a green top with a letter on the top that says E for epinephrine. Zofran comes with an O for ondansetron. There are multiple things that we can do. Plungers can be a different color and pre-filled syringes to let you know things. We need to speak out as clinicians through our organizations, professional organizations, to manufacturers, to the drug companies, saying, we want better. We are the consumer, and we have a right to go to them and say, this isn't working for us. So for us to sit back and continue to get these supplied to us, as me being in industry, I can tell you it can change. We have to demand it. So I want to encourage everybody, if you are involved in professional organizations, go reach out to your lobbyists, reach out to your manufacturers, let them know, get this out into the public, get this out that we need to demand better product as well, and not just put all of this on us, but put it on the people that we are buying the product from.
That's a great comment, and
Yeah,
I have a response. Oh, go ahead, Sabine. I'll go
yeah,
after you.
so
I want to hear your.
we 100% agree with you, and actually through ASAP tried to take a run at some of the government regulatory agencies to try to tell them that the pharmaceutical agencies need to make at least some of the high risk meds color coded uniformly, and they just more or less laughed in our face. But it's
Right.
always worth
Yeah.
another run. You have to knock on the door multiple times before it opens.
Right,
Absolutely. I think, yeah, we need to get nurses. We need to get paramedics. The ones that are dealing with these high risk administrations and coming in from the trauma and from the pre-EMS, I think it needs to be a joint force, a strategic plan to join forces to go in at this harder, because that could solve a lot of issues at the front instead of having to break through culture, break through the just culture and the time that it takes to change a habit. You know, the thing in industry with us is we say nurses and practitioners scream for change, and they scream louder when they get it. I give them a new product and they're like, oh God, now I got to relearn how to do all this. Let's change it at the front end of it.
right. Yeah, we have a saying in the fire department that we hate change and we also hate how things are. So it's the same kind of concept. But I'm actually working on a solution where you have to use a barcode scan on the medication. Here's what I found out. None of the barcodes are the same. So it's all because the pharmaceutical distributors, they're not on the same page. No one's forcing them into doing the same thing. You saw Ian's slide with, which looks obnoxious, right? The same drug 1,000 different ways. When you have an airline issue, when that door popped off that Alaska airline, I mean, it was on the news for like 25 nights in a row, right? You have people dying right now during this talk. Probably 10 people have died from a medication error, and no one's saying anything, right?
Absolutely.
The Wall Street
Absolutely.
Journal, the New York Times has put out articles. It's almost like people have become numb to it, which is pretty sad. But thanks for coming on and making your comment. And I think the collaboration between what EMS does and what we do in the hospital, speaking from someone who I have made tenfold medication errors, in my 25 years in the pediatric ER, and it's something that I still, these still today haunt me, which is why I'm trying to fix the problem as well. But it's a major problem. The high turnover at the hospitals are a major problem. And I just put in the link that Dr. Pupas mentioned. There's a paramedic who's been criminally charged for a medication error. That should scare the shit out of everybody on this call. Everybody.
Absolutely.
Because it's all going to happen to us or to someone that we know. And I would never want to see someone go to jail because of a system problem. And Paul mentioned it, and Ian mentioned it, and Sabina about, if we're really in a just culture organization, you don't blame the medic when it was really a system-wide problem. So really appreciate everyone's input. Ian, I'm going to give you the last word before we go over to Dr. Pepe's webinar. Let me tell Paul and Sabina, thank you guys so much for joining and supporting Ian and his work. Appreciate you guys coming on. And Ian, let's give you the last word, my friend. Thank you so much for coming on today.
No, thank you everybody that took time to be here. And same thing. Thank you to Paul and Sabina for everything, for your support, and even for just coming on today. You guys are phenomenal. And thank everybody for the opportunity, Dr. Intevi, Tanner, everybody that's normally here, Dr. Pepe. This was great. I really appreciate having the opportunity to be here today. Thanks.
Well,
Awesome.
I know you're probably running out of time, but I want to say it gave me goosebumps to hear you present, Ian, because what I've been trying to spread is coming out of your mouth, and it just, you did a better job than I could have done. And thank you so much.
Thank you so much. That really means a lot. I appreciate that.
Very nice of you. Sabina, take us out, Sabina. Come on. Last words. We got to get you in here.
So I think the final words are just, keep spreading the gospel. This is about taking the best possible care we can of the patient, of being medical professionals and doing the right thing, even if it's the hard thing. And keep on doing it.
Amen. Amen. And the Florida Center for EMS is here. We have a great opportunity in the state of Florida to evaluate some of these big issues. And so Florida is the place to be for EMS. So all of you folks who are not in Florida, Tanner, we want you to move here. Gordon, Larry. So, okay, guys, thank you so much. Have a great weekend and appreciate everything you guys do. Stay safe out there, and we'll see you next Friday. Bye, everybody. Please join the link on the right side. Go over to Dr. Pepe's webinar for more fantastic EMS knowledge.